Hello and welcome. Today, we're diving into a really powerful new tool designed to tackle one of the biggest challenges in oncology, pancreatic cancer. It's called the END-PAC score, and it's brilliant because it helps solve the critical problem of early detection using data that, get this, is probably already sitting in a patient's medical chart. So first, let's just talk about the stakes here. The 5-year survival rate for pancreatic cancer is a staggering 9%. And the main reason for that, the heartbreaking reason, isn't that the tumor is impossible to treat. It's that we find it too late. Something like 85% of cases are diagnosed at an advanced stage. Often then surgery is no longer an option. This is, at its core, a detection problem. So here's how we're going to break it down. We'll start with why early detection is so tough in the first place. Then we'll look at a really important clue that researchers have been zeroing in on. From there, we'll actually build the END-PAC score piece by piece, see how well it works, and then talk about what this could mean for the future of screening. Okay, so first things first, why is finding pancreatic cancer early so incredibly difficult? Well, it's pretty rare in the general population. We're talking only about 15 cases per 100,000 people. So screening everybody just isn't practical. You'd get way too many false positives. That means you need a much, much smarter strategy. And that strategy basically follows this 3-step framework. It's really elegant. First, you have to define a smaller group of people who are at a higher risk than everybody else. Step 2, you find a way to enrich that group even more, to really concentrate the odds of finding the disease. And then, and only then, do you bring in the big guns, the expensive imaging tools to find the cancer in that super high-risk enriched group. All right, let's look at that first step. How do you even define that initial high-risk group? For years, researchers have seen this really strong connection between pancreatic cancer and a very specific clinical event. And there it is. If you're over 50 and you suddenly develop diabetes, you have a 6 to 8 times higher risk of being diagnosed with pancreatic cancer within the next 3 years. So that's our high-risk group. But here's the catch. The absolute risk is still pretty low, only about 1%. That's still not high enough to start doing invasive screening on everyone in that group. This is where the key insight came from researchers at the Mayo Clinic. They realized that not all new-onset diabetes is created equal. You have your typical type 2 diabetes, which usually develops slowly, often with weight gain. But then you have this other kind, the one linked to pancreatic cancer, and it looks totally different. It often comes with unexplained weight loss. Your blood sugar gets worse really fast, and it tends to happen at an older age. And that's exactly where the END-PAC score comes in. It's a simple model built to put a number on those exact differences, using information that's already in a patient's electronic health record. So the first piece of the score is weight change. And just look at how it's scored. If you've lost a significant amount of weight, more than 6 kilos, in the year before your diabetes diagnosis, you get a whopping 6 points. But if you've gained weight, you actually get negative points, which lowers your risk score. Component number 2 is the change in blood glucose. And this is clever. It's not about the absolute number, it's about the velocity of that change. The score is based on how many glycemic categories a patient has jumped through in the past year. From normal to pre-diabetic to full-blown diabetes. The faster that rise, the more points you get. And the third part is the most straightforward of all, your age when you were diagnosed with diabetes. If you're diagnosed under 60, you actually lose a point. If you're 70 or older, you gain a point. This fits perfectly with that observation that cancer-related diabetes tends to show up later in life. Then you just add those 3 scores together. Weight change, blood glucose change, and age, and that gives you your final END-PAC score. It's so simple, you can imagine it being calculated automatically right inside the electronic health record. Okay, so we've got the score, but the real question is, does it actually work? How does it perform in the real world? Let's take a look at the data. This chart really shows the power of the model. Remember how in the big group of people with new-onset diabetes, the cancer prevalence was less than 1%? Well, if you use a cutoff score of 3 or higher, you suddenly isolate a much smaller group where the prevalence jumps to 3.6%. That is a 4.4-fold enrichment. You've now reached a point where doing a clinical workup starts to make a lot of sense. Here's another way to see just how useful this is. If you apply the score to people with just regular old type 2 diabetes, look at this. Almost half of them, 49%, get a score of 0 or less. The model is effectively telling them and their doctors, your risk is incredibly low. Just manage your diabetes as usual. That's huge for avoiding unnecessary tests. Now, in stark contrast, look what happens when you look at the patients who were eventually diagnosed with pancreatic cancer. A full 77% of them had a high-risk score of 3 or more. This tells you the model is incredibly sensitive. It's really good at flagging the people who absolutely need that closer look. So this all translates into a really clear, actionable plan for doctors. If your score is high, you get an imaging workup. If your score is low, you just get standard diabetes care. And that middle group, the intermediate risk folks, well, they become the perfect candidates for future research, maybe using new blood tests or biomarkers to figure out their risk even more precisely. So for our final section, let's just zoom out and think about the bigger picture. Because this isn't just about finding cancer. It's about finding it early enough to actually change the outcome.
And to really get that, you need to understand this idea of lead time. In this context, lead time is basically the window of opportunity. It's the time between when diabetes first shows up in your blood work and when the cancer is actually diagnosed clinically. The longer that lead time, the better your chance for a cure.
And this is where the model's true potential just blows you away. Its sensitivity stays high, around 75%, even when that lead time is more than 6 months. Think about that. The score can potentially flag 70% of these cancer cases more than 3 months before they would have been diagnosed based on symptoms. That is a game-changing window of time where tumors are much more likely to be small, localized, and treatable with surgery.